We are now. So yeah, anybody that does need to join late, they will receive a copy of the recording afterwards as well. So welcome to week 2. This is week 2 of the 6-week Triage Readiness program. Last week, in week 1, we were joined by our Accurate CEO and founder, Jacob Haddad, and also Manal Bakai from NHSE. They discussed how to get started with total triage and how to lead your practice through the change. Hopefully you were all able to join that session. If not, you can find that recording over on our YouTube channel. You should have also received this alongside the slide deck and some additional resources via email. If for any reason you haven't received that, please do let us know. It could be that you need to resubscribe to our emails in order to receive that. So you can do that via a link that I will share in the chat in a moment. Also, if you have any issues or need some further support, do just reach out to customer.success@accurix.com and we can help with any of that. As always, as I just mentioned, the session's been recorded. We'll share this with you later on today, along with another pack of resources. So everything that we kind of touch on here today, plus some additional to support you in your move. This is going to happen kind of each week as we go through this series. We're in week 2 of 6 now. And so you should be receiving all of the above in due course. Any questions that you have, please use the Q&A box. We have a number of colleagues online who will be able to help answer throughout. We'll also leave some time at the end just to ensure that you have time to answer questions live and speak with our guest speakers. So this week, we're going to be focusing on designing your workflows. So really building on week 1 and what was learned last week, we'll discuss how to clear the decks, design new workflows and processes, and discuss patient and staff co-production. We're joined by 3 guest speakers across 3 different practices. So we have Devin on the line, we have Bex Cotty, and we also have Johan as well. They'll be speaking through their insights and journeys to successfully implementing total triage in their practices. So a huge warm welcome to all of you. Thank you again for joining, and a big thank you to our guest speakers as well. They'll also be around, as I mentioned, for that Q&A. So any questions that you want them to answer, we will ensure that they get answered live at the end of the session. Appreciate last week we ran out of time a little bit with questions, so we'll hopefully have a little bit more time today. So just to introduce our guest speakers, as mentioned, we have Dr. Devin Gray. So she's a GP partner at Putney Mead Medical Centre in SWL. We have Bex Cotty, who's a business manager at Conisbrough Group Practice in South Yorkshire. And then we also have Dr. Johan Byron, GP partner at Crouch Hall Road Surgery in NCL. They're going to be doing most of the talking. I hopefully won't talk for too much longer for you. But before I do hand over to them, I'm just going to give a short introduction of what we'll be covering today and kind of some recommendations from our side before I hand over. So by this time next week, a few kind of bits for your agenda. You should hopefully be in a place to have a second meeting with your partners. So agreeing the ideal patient journey for you, deciding on which workflow will suit you best. And a lot of what we cover here today will hopefully support you in that. And then thinking through that clinical protocol as well. You'll be able to start thinking about your rota, so playing to your strengths and planning for your first 6 week of triage, giving adequate time to rearranging clinics and other responsibilities as well. And then finally, having a think about and hopefully putting in place clearing the decks. So when you do go live, making sure that you've kind of brought your appointments forward to ensure that within the first couple of weeks of go live, you have plenty of space within the appointment book for patients to then book into. So some key principles I just want to touch on before we do hand over. So these are key principles to consider for your workflow. We recognise that every practice looks really different, and looks, a bit different here. You've got different resources, you've got different mixes of staff, different demographic of patients. You may have your own ways of working, but there are a few things that we've learned along the way that need to be kind of consistent across triaging workflows if you want triage to run well. So the first one being making sure that your triage is in fact total. Even if you have the best triage clinicians, The whole process may fall down without using reception flow and having a clear, consistent process to record all patient requests that haven't come via your online form or the NHS app. So patients that are still coming into your practice via phone or as a walk-in or using traditional methods like sending a letter to you, how are they being triaged and how are you ensuring that you're getting all of the same information from them as you would if patients were coming online? And this is where reception flow is really crucial. So this is your front door to the system, essentially, how those requests are coming in, how they're being logged and how they're triaged. Then moving on, we have triage here. So making sure that there's like skilled and clinically informed triage happening. The people doing that triage will definitely need to be confident and be able to make quick, safe and informed decisions with the triaging requests that come through. So those best triages are comfortable holding some level of risk and they know when to escalate as well. So this isn't just about ticking boxes, but really about applying judgment in real time to all of those requests that are coming through. Safety as well. So as a clinical team, agreeing on your triage criteria in advance, really having clear protocols for different request types. So clinical versus admin, urgent versus routine, ensuring consistency and reducing variation and supporting that safety piece is really crucial here, especially when different staff members rotate through triage too. And then we have capacity. So using that skill mix and also local services to kind of alleviate some of that capacity on your practice. Triage isn't just about filtering through all of those requests that are coming through, but about making sure the patient gets to the right person the first time. And this is basically a big theme throughout all of this. That means using the full range of skills in your practice team and then linking in with local services as well, where that is appropriate for the care that they need, avoiding any unnecessary duplication and really just working to improve the patient experience. And then finally, here we have async. Apologies. We have async. So where safe and relevant support the patient, you can support the patient asynchronously. This will help save loads of time for you, hopefully. So breaking it down then, we have a 4-step workflow. So NHS England actually breaks this triage process down into 4 main chunks. And it's a really helpful way to think about it because each stage has its own set of decisions and challenges that come with it. So contact, first of all, consider which routes patients can use to get in touch. Is this the online form? Is this the NHS app? Is this via the phone? Is this as a walk-in? Ensuring these are accessible to all patient groups and establishing whether all requests are processed in the same way, regardless of the route that they've used. So making sure basically you're maintaining equity there. This is where reception flow comes into play and is really, really important. At the point of initial contact, determine if you have enough information to make a decision. So this is the assessment at point of contact. This may involve sending follow-up questionnaires, so utilising some of those different parts of your Accurix toolbar, requesting images if you need some further information from the patient, checking patient-specific details such as their usual GP as well, and then making sure that that adequate information really just is improving the efficiency and safety and you have it all in place to make those informed decisions. Prioritization then, so implementing an agreed method for determining urgency and acuity. So use clear shared clinical protocols here. Do you need to include red flag criteria? Defining those responsibilities for monitoring each category of requests to ensure really consistent and timely responses are able to be made. And then finally here, the 4th point that they make is deciding on the most appropriate modality for the patient to be seen. So is this face-to-face? Is this over the phone? And which member of the multidisciplinary team is going to manage that request? Where appropriate, do signpost patients to alternative services. So as I mentioned, those local services, potentially, community pharmacy, they can be signposted to, as opposed to leading to an appointment at your practice if it's not necessarily needed. The aim, again, is to just really direct patients to the right person first time within that appropriate time frame. So just going into that in a little bit more detail, we have the contact phase. So a patient then intending to contact your practice, and there are a few routes that they can take to do so. So are they coming in as a walk-in via the phone lines, or are they coming in via the NHS app or your online form? An exciting piece that we want to introduce here is soon we will be launching our digital front door. So signposting with this digital front door at first point of access into your practice. So this is going to help create kind of consistent entry point for patients, standardizing those access routes and hopefully alleviating some of that demand on your practice, as patients will be able to be signposted elsewhere, as I mentioned, at that kind of first point of access to you, as opposed to the request coming through to your inbox. If your practice wants to signpost earlier in the process, it's really essential to have clear internal guidelines and agreed routes for signposting to ensure consistency and fairness. So just ensuring that everybody is singing from the same hymn sheet there. They know that internal protocol, they know that procedure that you are following. Consider how you can encourage patients to self-serve as well for future requests. So sending them the link to complete the online form themselves if they continue to come in over the phone lines or as a walk-in. How can you educate them to basically move online if they can do so? Can you send them a link with a direct link to your patient triage form or to the NHS app, so they can re-educate and then use those online services as opposed to those more traditional methods. We found that a large proportion of efficiency gains in triage come from refining this context stage. So really just getting this right will hopefully support you further down the line as well. Assessment then, so basically asking yourself, do you have all of the information you need to deal with the request? Think about how you handle requests that require more information before they can be triaged. These can often create delays if they're not actively managed. So do you need to use kind of those other parts of the toolbar that you have available to you to gather more information? Can you send questionnaires or individual responses to gather more information and then move them to an awaiting response for triage folder potentially? You will receive all of this information in the deck as well, so you can kind of look at these flows in more detail in your own time as well. Practices report that around 30% of patient requests actually fall into this category, so awaiting more information. So really having a structured process here can help significantly improve that flow, so that you are getting all of the information that you need to make the right informed decision. And then finally, before I hand over to Devin, just that prioritisation and allocation piece. So clarifying when patients should be phoned, how home visits are prioritised, and what happens for urgent requests or embargoed appointment slots. So in smaller practices with limited capacity, the triage doctor may need to action requests directly rather than reassigning them to admin staff. Consider whether your inbox is organized into multiple team folders, for example, prescriptions, RAG-rated requests to support faster allocation within that. And then ensuring there is a clear process for confirming that a patient books any appointment that's been offered to them. So in short, effective triage really relies on 4 things working together incredibly well. So having that clear and accessible patient contact route, good information being gathered at the first touch point, and then how are you gathering further information if needed, and that consistent prioritization based on agreed clinical protocols, and then finally smart allocation to the right person or service at the first time. So getting each of these right not only improves safety and patient experience, but it also just makes that whole system far more efficient. But enough from me. I've spoken for long enough now. I'm going to hand us over to Devin. So Dr. Devin Gray, GP partner at Putney Mead Medical Centre in SWL. She is joining us today to speak about her practice's journey to total triage. So Devin, I will let you take it away.
Thank you. And thank you for having me. I think it's really brilliant to have the opportunity for people to hear about how we've actually done it in different practices, because I spend a lot of my time talking about the principles of triage, but sometimes you just want to see how someone's done it. And I would certainly encourage anyone on this call, if you've got a neighbour who's doing total triage, go and see it in action, because that's where you really learn about the bits you would like to take away or not. So I'm a salary GP at Putney Mead, just to clarify Kate's introduction there, and I'm clinical lead for digital transformation for one's with GP Federation. And we have been using Accurix in a triage capacity since January 21. So quite a long time now. And we first introduced it during the pandemic, when by definition we were doing total triage, because you couldn't get an appointment without it being triaged at that point. But we slipped then into this slightly murky dual system when things started opening up again, and we had what would probably be best described now as a partial triage system, where we encouraged as much through the form as possible, but there was a meaningful kind of bypass route. In November 23, we kind of made the decision to go total triage, and it was a bit like starting again, particularly because we had to unpick some of the things that had sort of slipped since we first started it. So this was really, really carefully planned, and we've made very few changes to it since November 23, and we think it works really well. And I'm going to leave this slide up for a while I'm talking, because it does, it's quite a simplified but helpful visualization of what we do. So you'll recognize the first part of the graphic from the Modern General Practice Access NHS England work, but we've edited it to show exactly what we do. So we have a team of GP assistants. They were receptionists at our practice that we upskilled, and they have a dedicated role within the practice to manage triage and to work with the triage team. And depending on the size of your practice, that can be really powerful. And so the first thing we do is we have a first sift. The GP assistants are in that unassigned box, and the first thing that they do is work through and sort into various boxes what needs to be there. They're not doing any kind of clinical triage. It's just, oh, that's a reception query about a change in address or a new registration, that goes in that box. The secretary's one is more about referral queries, admin is doctor's letters, prescribing is obvious, and anything that is requesting an appointment that needs to be triaged in some way, so anything that isn't a blood test, that isn't a smear test, goes into a box that we call for GP triage, to make it super clear what it's for. So then within our duty team, we have a triage GP and a duty GP. And depending on the day of the week and the time of day, we often have two triage GPs. Putney Mead has 25,500 patients, so we're quite a big practice, but we match it entirely on demand. So on a Monday and Tuesday all day, we have two triage GPs, and then as the week goes on, those numbers start to tail off, so that by Friday afternoon, there's only one triage GP there. In the second half of the week, the afternoons have only got one triage GP. So one thing that the kind of main features of our triage system is we have a strictly one-way flow through the system. This is particularly important for bigger practices, because we can have hundreds of requests in an inbox. And if you've got information going back and forwards into the box, it all becomes a mess. If you're a small practice, that might not be as important, but we don't tend to put things back in the same box again. So it goes very much one way, like a vein with valves. So it goes from the to assign box. If it needs triaging, it goes to for GP triage. And then there are two different boxes that our triage team will put those requests into. And the way that I see it, it's really asking the question, does this patient need an appointment in the practice or not? So if they do need an appointment or a service, the recommendation goes on that as a form of a yellow note, and it will say, this is a routine appointment with a GP or a PA in the next however many days. And then that goes into a new box called action from triage. If it's something that the GP can resolve themselves, they still need to get it out of that triage box because they've triaged it. And so they put it in the doctor's box. And that becomes a workflow of things for that triage GP to work through during the session. It's things like fit notes, it's referral queries, it's things that they know I'm going to be able to resolve that without an appointment. And it's where a lot of the magic happens in terms of actually freeing up capacity, because these are things that often would have ended up in an appointment in some way or been squeezed onto the duty list. So a lot of this real time saving that happens in that doctor's box. And then from there, the GP assistants are working to action those triage requests. So if it's come down now for an appointment, they'll pick up the phone. If it's please send them a booking link for a routine physio appointment, they can do that. Anything that the GP assistants can then do will do so, and then things get closed. We have really noticed, again, just coming back to this one-way flow, we've had incidents where if you allow things to be moved around in the box quite a lot, they can end up just being endlessly in the system. So I do the triage system on a Monday afternoon. It's not uncommon for something to kind of land back in the inbox that has been passed amongst people for a few days, and actually in that time the patient never got a response. So I'm quite keen to keep to the one-way flow, and I think it really works. Another thing that works really well is we have really clearly defined roles and responsibilities. So each of those boxes you see have got someone who is responsible for checking it. So the receptionists, the secretaries, the triage team, the admin, the prescribing, everyone knows what they're doing and what their responsibilities are. And actually, if you go to the next page, I'll tell you a bit more about how that works. Thank you. So we call it the hub. We are all physically in one room. Again, that is not a privilege that all GP practices have, but if you can create the space, we sort of sliced our meeting room in half and put some desks and some computers in there. It's really worth doing. So we have up to 3 GP assistants. They all sort of start in a staggered way and finish to cover the full day, and we do extended hours. So there is someone there between 8 and 6:30. And the duty team are even there till 7:30. So we have up to 2 triage GPs. You saw the duty GP, and we also have a pharmacist. So those, you can see the boxes on the left there, but you can go on to the next slide, Kate. Thank you. So I've just outlined there, sorry, back a slide. Yeah, that one, thank you. All the things that they're doing. So to start with those GP assistants, I think it's helpful when you're planning to also look at this angle, or what are the roles and what are they actually going to be doing. So our GP assistants are carrying out that first sift. They're carrying out all actions from the triage box. They'll pick up the phone and call patients for same day appointments, or those that didn't fill out the form themselves. They will monitor and manage capacity. This is really key, and it's been really successful for us. We give a lot of autonomy to the GP assistants because they are in that hub room Monday to Friday during all the hours that we are open. They know who's off sick, they know how much capacity we have, whether or not someone's had to leave the clinic halfway through, and all of those appointments have had to be reallocated. And they are given the authority. For example, we always have a clinic that goes on the day, and they can put that on a little bit early, for example, if they realise that we're getting sort of too tight on the capacity in the evening. So when you come in as the clinician, the first thing you do when you check in with your GP assistant is to say, how are you? How's the day going? What do I need to know about the capacity today? And we have a constant dialogue in the room together about what's happening. They'll say, oh, we've got a 4 o'clock appointment coming up. Can you make sure that you prioritise the triage box? We don't want that to get wasted. And they also manage this sort of informal continuity list. I wouldn't say that we have a waiting list, and I would try and avoid that in your planning. But if someone has been on holiday for a couple of weeks, we do want to encourage continuity. And if the patient is happy to wait, they do have a sort of a holding box where they are waiting for the templates to go on for routine appointments where the patient really needs continuity. Again, you have to be really careful for that, because that could end up consuming a lot of time, but it's just about getting the balance right. Quick onto the triage GP. Oh, the other thing they do is they have a whiteboard, and some days, depending on preference, it's a physical whiteboard, and they're writing all the appointments on there, and they scrub them off when they're gone. More recently, we're trying whiteboard through MS Teams so that it's done digitally, but just having a really clear live picture. You can, of course, just use your templates as well, but we're a big practice. You have to scroll quite a lot to see all the available appointments. So we really like to be able to see with just one look, okay, we've got 3 PA appointments, 2 ANPs and 1 GP left for the rest of the day, so that I, as the triaging GP, can really make sure that we're doing this well. Triage GP does what they say on the tin, but they also create this and complete this admin list. They'll triage any ad hoc demand, and by that I mean, you know, if someone walks in downstairs, in demanding to be seen, they'll pop downstairs and work out what's trying to go on. The nurse comes in with an ECG, whatever it is, or someone goes off sick last minute, and that clinic needs to be triaged. They're responsible for all of that. And the duty GP is taking on that more traditional role. They're doing urgent calls, people that can't come in, maybe they're out of area, it's a mental health crisis, they're sorting out an end-of-life care patient, taking calls from the ambulance service, doing urgent home visits. And if they need to squeeze in an extra face-to-face, we have got a room that they can pop down and see a patient, although amazingly, that's really quite rare. And I remember the old days of duty where you were constantly juggling calls and seeing extra face-to-face. And, you know, if the nurse pops up and said, can you come and have a look at a wound, they'll run downstairs and do that. And then finally, we have the pharmacists. They have an urgent prescription query template, which can be booked into, and that will get filled up. But what's so crucial about having them in the room is that so many of the queries I'm dealing with as triage GP are about prescriptions. And it's so helpful. They're always tricky questions. So having them there saying, is this on the formulary? Can we do this? They're within the room, they're probably the person I speak to the most. And it's so wonderful to have that physically in the room together. Next slide, please. Just a quick, I might not read through all this, but just to say that outside of that physical hub room, there are of course people behind the scenes. The receptionist will be managing any reception queries. These things all still come through our triage system, but this is who is dealing with it. And I'll let you look through that because I'm conscious of time. So this is how, and in every area it's going to be different, but when we're triaging, this is what we're thinking about. These are the sort of slots that we have. And if you're interested in how we physically do that, we have whole clinics that go up on the day. And we also have in every routine clinic 2 red slots, which shouldn't be booked into in advance, so that you can also have on the day demand with a specific GP, and we use that to try and keep continuity. So if it's a complex patient who has a named GP, much better to book them a same day appointment with a GP that they know than for it just to be whoever has a clinic going up on the day. We have increasingly over time as well, our PAs do a lot more on the day minor illness. So they see a lot of we're very cautious about how we triage to make sure it's appropriate for their skill mix, and those PAs are supervised by a different clinician that is not in the hub, because actually the hub is too busy to throw supervision in there as well. This is, I just wanted to include, I do this as part of our triage training, both within the practice, but I do it across Wandsworth. And this is really just when we're writing our note, we try and follow this. I'm sure anyone who's using some kind of triage at the moment will do this, but really thinking not just about, is it urgent or routine, telephone, face-to-face, who. I often will give a selection of options to give the GP assistants the autonomy to say, okay, she said it could be a GP, a PA, or an AMP. I've got loads of AMP appointments, so I'm going to book them in with an AMP. So if that is an option, I will give it. And if it's not, then I won't. And we try and recommend a doctor. If it's clearly a follow-up, we'll put the name of it on there. And I really like why, because I'm trying to support my GP assistants. If they've said urgent severe abdominal pain been going on for 3 years, I might triage that as routine, depending on the circumstances. So then the receptionist can understand why it's being triaged as routine, even though the patient said it was severe. And I've just done on the next slide a quick screenshot of what the hub templates look like. So those pink slots are the duty GP, and the GP assistants will book them in based on our triage. Those green slots we use ourselves just really for auditing and to sort of make sure that we're capturing that we are saving capacity. So we book, if I'm going to close off a consultation without making an appointment, I will put it in there and draw a line across it. I think that's me nearly done. Are there any other slides? This is just a very quick on how we cleared the decks. We started a bit like when Christmas is coming up. We just started to reduce the appointments that you could book into, which really kind of forced us all to absorb more and more capacity on the day. We put some locum sessions on in advance to absorb the capacity in that last week, tried to minimize any non-clinical sessions, and tried to have a bit of team camaraderie about understanding why we were all clearing the decks in those last couple of weeks before we went live. And it was great because it was so amazing to have the reduced stress of essentially cleared appointment books when we went live.
Amazing. Thank you so much, Devon. Really, really, really appreciate you coming and talking to us today. Devon will still be online to answer a couple of questions at the end, hopefully. But I'm going to hand over now to Bex from Conisbrough Group Practice.
Hi there. I'm the business manager at Conisbrough Group Practice. I'm an Accurix ambassador as well, so I've been involved in a lot of training with practices in our area in particular who want to come in and see how our triage works. We've also been triaging total triage. We've been total triage for many, many years, pre-pandemic, but it was telephone triage. And then the pandemic hit and we moved to Accurix when our telephone systems went down. So we had no time to plan, prepare. We were on a burning platform and we just threw ourselves into it, and adopted very much the telephone triage method, but using this as the way in which we would gather the information to triage through. So we are a 12,000 patient population, and yeah, we moved to total triage on Accurix in October 2021. We cover quite a deprived area of South Yorkshire, and we have a very, very varied staff mix. We have 6 partners of varying sessional rates, 2 salaried GPs, again, not both full-time. But we have our training practice, and currently we have 12 registrars, which is a luxury and a lot of hard work. We have a paramedic, a physician assistant, an A&P, 2 nurses and 2 HCAs. So that's our spread. Plus we have other staff from our network, such as clinical pharmacists and care coordinators. We moved to total telephone triage. We moved to total triage on Accurix, like I said, because we didn't have phones. The actual system went down and we didn't have it. We needed to offer our patients another way of contacting us. And we see this as another door rather than the only door. However, whichever door you enter our practice through, whether that's the front door, the telephone, or online, everything comes through Accurix. Doesn't matter whether it's an admin query or a medical query or chasing something up or repeat prescription, etc. Everything comes in via Accurix. Have the next slide, please.
Of course.
So we stole Accurix's little template here for the flow. And as you can see, regardless of how the patient contacts us, whether it's walking in, online, or on the phone, it goes into the unassigned box within our triage. So the patient request lands in there, or the patient walks in, our care navigator or reception team completes a patient triage form online on behalf of the patient. And currently we've just introduced a new piece of software that means if the patient phones, we have Emma, the virtual receptionist. She asks and completes the patient triage form, whether that's medical or administrative, etc., on behalf of the patient, and submits that also straight through Accurix. Next slide, please. So everything, as I said, goes to the unassigned inbox, and then it gets split. And this can be done by the triaging clinician in our practice. That is only done by the partners. As Kate said at the beginning, triaging takes medical knowledge, an ownership of certain level of risk, and there is an awful lot of nuance involved, especially when patients send you information. So we decided that our partners would do that because they can do that and other things within practice as well if they are the triager on the day. They are also our duty or on-call doctor, but they never see patients anymore. It's literally there in case another clinician needs a second opinion. They can pop up and just ask the questions and have a quick discussion. So medical requests, as you follow this flowchart, the medical request comes in. If more information is needed, they send a questionnaire for an individual response to the patient, or a flurry from Accurix, a standard one, or any of the multitude of templates that we've already generated. And then no further action is done until that response is received, and it will come back because it will be reopened when the patient responds. If no more information is required, then they can request, it can be requested to be managed, or it can be closed without needing an appointment. As we said, there's some things that can just be actioned very, very quickly. We could send them information about another service and ask them to self-book, or we can ask them to come up for an appointment. An appropriate appointment can be decided on with the variety of clinicians that we have in practice. And if the appointment needs to be booked quickly, i.e. within the next hour and a half, then the care navigators are sent instructions to contact that patient with an approximate time and with which clinician has been deemed the most appropriate. If the patient can't make those times, then a message goes back via clinical system instant messaging service to just say, I can't make that time, when else can I offer? Because as I'll explain very shortly, our appointment system is very tightly controlled. And then if nothing is needed, then, and the patient is satisfied, we don't hear anything else, and that's fine. They can self-refer into our MSK services, or they might be signposted to our eye care service, etc., etc. So all those things that are navigatable for practices in your area, whatever's unique to your space. Next slide, please. Importantly, how we cleared the decks. So this comes down to the preparation that you have on your appointment system. So although I said we've been total triaging through Accurix for quite some years now, we still tweak, we still monitor, we still look at our data very carefully. We still use our Accurix dashboard very, very frequently, and look about what works and what doesn't. What might we be short on and what aren't we short on, and what do we have difficulty utilizing or maximizing the utility of. And one of the things that we find is we don't book ahead. Everything is dealt with on the day. And we, oh, the slides just disappeared. There we go. Everything is dealt with on the day. So what we did was move everything that was 6 weeks ahead. That was our kind of, 6 weeks was on the clinical system, and everything after that was going to be changed into a new system. Our follow-up appointments happen first thing in the morning, as much as humanly possible, along with telephone calls, because we have the ability to give ourselves breathing space to manage the influx of requests that come in first thing in the morning. So we still have, and again, this isn't because of total triage or anything else, it's a cultural thing in the UK. Patients still like to contact their GP at 8 o'clock. They still think there's a mad rush. Some are starting to learn, the curve is flattening out a little, but it's still taking years of practice. So we don't book ahead, but it meant that if we put in pre-bookables at the beginning of the day, so those are things for follow-ups or where continuity of care is absolutely essential, then we put that at the beginning of the day, and then we've got some breathing space for the person who is triaging, not to be in a mad rush to book things in and say to the patient, can you get here in 20 minutes or half an hour? It kind of gives a bit more time, and also allows us to cope with people calling in sick and capacity change happening and so on. So we have been tweaking. We signpost like crazy, so Pharmacy First and all the other services that are out there. Somebody who's triaging should know these services, or at least know who to ask about what services are available. And the triager, or the person who is on that duty all day in our practice, has help for at least the first hour of the day from another partner, and they can be used how they wish. Some triagers are, I'm fine, I've got this, I prefer to just work in my own little bubble and get on with it. Other people like to use people to make calls, find out further information, send out the flurries, sort out the sick notes, that kind of thing. So it varies from triager to triager. And if somebody can't triage very well, and this isn't something luckily we've had to do in our practice, but I know I visited a lot of practices over the years, and it is worth having a conversation with them to say, is this really the role that you need to play in this practice? So that is pretty much where we're at. Our care navigators, although they're called care navigators, don't really care navigate. They are the ones who are the link between the decision-making of the triager and the patient appointment or signposting to wherever the triager deems it most appropriate for them to be moved to. So any medical decisions are made by the triager, regardless of what level that needs to be. I hope that was a quick whistle-stop tour. And we'll deal with the questions later.
I think there are a couple of questions in the Q&A. So if Devin or Bex, if there are any that are like directed towards you, then feel free to.
Will do.
But say Kat would like to answer this question. Should we not answer those?
There's a bit of feedback coming from somewhere.
Yeah, Johan, I think that's your feedback.
Yeah.
No, all good. Sorry, what was that, Devin?
So it's just to say, for the ones that says Kat would like to answer this question live, should we not answer those, or should we answer any of them and we can always pull them out?
Yeah, go for it. Absolutely, jump in. Just want to check, can you still see my slides okay? Because the screen share on my second screen was having a bit of a mare just then during Bex's.
No, they've gone.
They've gone. Bear with me. Johan, do you want to just introduce while I get the slides back up?
Yeah, absolutely. Is my mic working? Can you hear me?
Yeah, all good.
Fantastic. Hi, everybody. I'm Johan. I'm a GP partner at Crouch Road Surgery in North London, in Crouch End. We're an 8,500 patient practice, and like Bex, I'm also an AccuRx ambassador. So had the privilege of kind of training other practices to be able to make the move to total triage and use the product, the AccuRx product. Really funnily enough, looking at Devin's presentation and Beck's presentation, we've done this independently, but the systems that they use are exactly the same as what we do. And our system looks completely different to when we first started about 3.5 years ago. And what I found was over that time, why we've changed to the way we are now is that we've focused on understanding the why of what we do, of the why rather than the what. Of what we do in total triage. So what I thought was, rather than show you what we did, because you've got a really good example with Devin and Bex, just to really talk through some of the underlying principles. Every practice is going to be different for 3 major reasons. Patient demand changes from area to area. The clinicians in your practice, so whether they're specialist skills or special interests, will change from practice to practice. And also what services locally for you will also change. So those are the 3 things as to why there might be small nuances between different practices when you design your workflow. So yeah, we moved to total triage about March, April 2021, and AccuRx as a product shortly after that. The reason why we moved to AccuRx is because we found that the first product we were using for eConsults, whilst we'll receive something from eConsult, would then send a message through to AccuRx via AccuRx. And it didn't make sense that you were using 2 different products for communications in and communications out. Our patient list size, as I said, was 8,500. It's a mixed population, so young families to the older population. We're slightly blessed in the sense that our older population are digitally enabled. And if they weren't, one of the priorities for us in reception when they would come in and either register or request an appointment was to actually do a quick tutorial on how to submit a request, or now how to use the NHS app. Our staff mix has changed over the last 3.5 years. So we're now 2 GP partners, 7 GPs, 2 clinical pharmacists, 3 GP assistants who are all doctors. They're internationally qualified doctors working towards their PLAB, and 1 physician associate. But when we first started, we were just 3 GPs and 2 clinical pharmacists. So there is something about the model that we run being really attractive for GPs wanting to come into our practice to work. And why did we move to total triage? So lack of clinicians. So being only 3 GPs in the beginning, looking at not just seeing the requests, but seeing patients, what we found that you're able to get a really good view of what's coming in. And there was an unprecedented demand for things that were process driven, things that we could have dealt with either asynchronously or through admin routes, rather than them always being a telephone call or a face-to-face. We're also a really small building, and it's a relatively sizable list for the building size. Kate, if you don't mind going to the next slide. So workflow principle 1, automate the processes that hold the lowest clinical risk. You'll see lots of digital products out there that will try to automate what clinicians do. I would suggest actually start with the ones that don't hold clinical risk. So for example, really do push, and the immediate benefits we found were patient-led submissions, not reception-led. So agree with the principle that Bex and Devin said, and Kate, everything comes through Total Triage, comes through AccuRx, be it reception flow or through patient-led initiation. What you're hoping over time and the success of your receptionist is to drive those percentages to have a larger proportion of patients submitting their queries over a year or 2 years on their own independently, rather than it being reception driven. And the reason for that is it frees up a massive amount of time from reception. We went from 3 receptionists to 2 receptionists, and that receptionist goes upstairs and does adds capacity elsewhere. The second thing is, how are you going to make sure that, why would you do that? So investing the training of your patients and gives you an ongoing recurrent saving. So if you educate someone once to do their own online submission, the next time they need you, they'll go straight online, and it will be one less telephone call to encounter, less demand, and telephone calls require people to do it. So really do focus on the transformational change versus the transactional change. So just like you've got markers of success for your clinicians, how many patients they see, how many triages they see, your marker of success for your reception team is going to be, over time, are they doing the education piece that converts the number of patient-initiated requests versus those that come through reception flow? One big thing, education starts on registration, not on appointment request. So if you want to prevent someone calling you or having to do that reactive education when they do phone to say, do it online, what we do is we send a quick summary when someone, as soon as they register, we signpost them to our website, which educates them and show them how they make an appointment request. So do it on registration going forward. And this principle for automation is applicable to all aspects of your workflow. And if you can go to the next slide, Kate, I'll show you what I mean. So these are just 2 examples. So Total Triage, this is from the reporting tool. So always get data, and AccuRx is really good at giving you data. This doesn't look as good as some practices, to be honest with you. So our Total Triage example, everything that comes into our practice comes through and is displayed in that first bar chart. So 65% of requests are completed by patients, and they're submitted either online or through the app. Our next stage, because we started pre-app, is to convert as much of that online activity through the NHS app, and 35% is still through reception. I just want to caveat this. Absolutely everything comes through Triage. So if there is an email that comes through that requires a clinician to have a view of it, it will be manually converted by reception into a Triage request, and it will still flow through the Triage. So if we look slightly larger in terms of the proportion of patients coming through the reception flow, it's because we include absolutely everything through that. So there might be a manual email coming from a pharmacy for a script request, that's a query, and so on. When I said that this principle applies to other pieces of workflow, Devin said this really well. When we first started doing Total Triage, we had a view of all the requests coming in. The biggest burden was prescriptions. And it was patients that would do manual prescription requests in the traditional way, and that will come through Total Triage. So when we saw this was a trend in 2021, that there was a lot of prescription requests clogging up the box, we started an initiative to try and automate that process, not in terms of prescription signing, but actually how patients are requesting their prescription. So this is just a quick EMIS search side by side. You can see 2021 and 2025. This is where we were, and this is where we are now. So broadly, the 3 ways that prescriptions come in. If they're through the practice, that's a manual repeat request in EMIS. So reception are clicking request issue and the GP signing it off. Number 2 is pharmacy. So this is if you're in EMIS, some pharmacies have a product called ProScript where they can request directly into your EMIS medicine management module. And number 3 is through patient access. So either the NHS app or another product that requests directly into your medicines management module. So when we picked up a trend to say that, okay, this is the biggest or high volume piece of work that could be automated, what we then did was we went to our pharmacies to see who had ProScript, and we switched that on and gave them a bit of education. And we went through the NHS app and did a bit of education to say, this is how you request your repeat prescriptions. And this is the result so far. So this is 2025. We've gone from 88% of or prescriptions being added manually, so coming through reception flow and through the triage requests. And now we've been able to reduce that to a manual request of 52%, and it's a work in progress. And that again is part of our reception outcome in terms of success. Okay, if you can go to the next one. Number 2, so principle 2 is having the most experienced clinician at the front door and during the implementation phase. So if you're a manager or a digital lead that's not a clinician, Triage is a clinical tool. And so you should be supported from the beginning of this journey by a clinician to help sense check the decisions that you're making around the system. Why? Well, if you can understand the possible outcome for your patient, you're most likely to understand how they can receive help in the most efficient way. I use this example, and I think it's further down there of straight to test. So when you do a 2-week wait referral for cancer, you get a telephone call and you go straight to the investigation before having the consultant follow up. Now, that's exactly what you can do for certain cases of your workflow in total triage, where actually before you have the appointment, just say a man with urinary frequency, you would rather get all the investigations up front before you see them in the clinic for the examination, and it shortens the clinical pathway. Rather than 2 appointments, it's 1 appointment. These are the things that I would think about. Observe trends. So I think just as Beck said, you've got a clinician doing triage. It's always worth having a partner that sits just outside that, just to observe the data and the trends in how requests are coming through seasonally, so quarter by quarter, but also the nature of the request to see whether that could be done in a better way. So observe trends in demand, so acute versus chronic, depending on time of year. Observe the opportunities to reduce the demand via automation, and that was the prescription request piece that I showed you. Observe the opportunities for improving the clinical pathway, so this is the straight to test principle, and observe the opportunities to use capacity and other services, and this is signposting. There is a feature on your triage module, on AccuX Triage, where you can have a self-referral portal where you can create local self-referral. So we've got self-referral for physiotherapy, self-referral for counseling, and I would look to signpost patients to those to get them to do the work themselves. I'd also have, if you don't want to do that, you could do it on your website, but we put all of our self-referral services on the same page. So just say someone's going to self-refer for maternity, they also opportunistically see that they can refer for counseling or refer from physio, and that's another good way of educating the patients to see what's available. Training. So as I said, triage is a clinical skill. Locally, so when I worked in commissioning, North Middlesex Hospital had GP at the front door, and it's a really good example. They used to have a senior GP that would triage patients coming in, and they noticed a large proportion of patients going to urgent care rather than clogging up A&E. And then they had a junior clinician that then they substituted instead of the GP, and they noticed more patients would go to A&E rather than urgent care. So really important to have a senior clinician at the front. And as Beck said, actually really importantly, just because they've been around for a long time doesn't mean they're good at triaging. So it's real, and sometimes we find the trainers are quite useful and quite good at doing that. So don't assume a GP knows how to do it. Your own triaging behaviors changes over time, and it's really useful, as Devon said, to get everybody in the same room as they're triaging, because you do learn from each other and you learn how to work as a team as things go forward. Kate, if you can go to the next bit. Thank you. So I actually use this at an AccuX conference. It's one of my slides from my presentation. Just a brief adage, and use this template every time you design a workflow. So if it's a UTI workflow, because you're getting loads of UTIs coming in, and you think, hang on, we can do something really interesting here, eliminate, automate, delegate. It's a really good framework to use. And I've given examples briefly. I know you're going to get the slide deck, so I'm not going to go through it. But for a UTI, for example, reception, it doesn't need to be a phone call. get reception or get the person receiving that query to send the UTI flurry. So when it comes to your clinician that's going to deal with it, they've got all the information they need to make a clinical decision. Currently, GPs might be handling UTIs, then put the training program in place in order to delegate. Do the transformational piece of work in terms of workflow with your experienced clinician before you decide to delegate. So don't just delegate down, do the transformation before you do the delegation. I know we're short for time, Kate, so we'll go on to the next one. The last one, think big. If it doesn't scale, it's not sustainable. So I'm 8,500, but I've got to think like Devon at 25,000. That's really important. If pathways, if you're creating or refining your system, every pathway must be scalable. So it needs to be able to handle growth in demand, practice size, or complexity. If it's too big, if the pathway is too long or too complex, it's and not easily understandable, are you actually triaging, or are you just simply doing the consult for the patient? And this is one of the biggest things that we've learned. So when we started to take on new GPs and they get a triage request, actually they're not triaging anymore. They're not trying to answer those questions, right time, right place, right person. What they're doing is actually doing a full consult, and they should just call the patient. And that's the check. That's what they need to ask themselves. And that's really important. We're a small practice. We don't have the size, but we did create a single hub where everybody can sit together and work. But the digital estates versus physical estates piece is really important. The largest square foot in every practice is the waiting room, which offers no clinical value. So as demand increases, you can't keep building rooms. So see how you can try and shift some of this demand into the digital estate that's limitless. Building flexibility. So as new pathways come in, so with the new neighborhood models coming in, proposing different things, make sure that you're reviewing your workflows to local services where you can shift demand, or priorities of the local area. Monitor and iterate. So metrics are really important. There are things that you think are really important when you're triaging and you think you need to work on it, but the data shows you that actually it's low volume and there's less value in trying to work on that. But there may be something coming in high volume that's worthwhile your time in the future, in the immediate future. I've just got I think it's just one more slide after that. So yeah, so our digital organization reflects our physical organization. So I just wanted to show you our teams list, and this is what we have. Just at the bottom, you can see virtual waiting room. And so the team virtual waiting room is monitored by our reception. So if someone came in and they were waiting for an appointment because something was happening for them, they would be waiting in the waiting room. So what we wanted to do is reflect that in a virtual space. So they've sent in a query, but we're waiting for more information. We don't want it to clog the triage doctor's box or the doctor's box. So we put that back in the virtual waiting room, and that's monitored by the receptionist. And as you saw in the beginning, we've got a reduction in incoming phone calls. Now we're doing much more outbound phone calls where our reception team are proactively chasing the information we need in order to close the query down. So we've had an opportunity, when we've had an opportunity to improve the pathway digitally, we ensured that it was reflected in the physical space. And that was really important. So what we found over time was that we had loads of teams. And then what we did was rationalize them down into smaller teams or smaller functions. We've noticed that things have become less busy. We've literally built a new clinic room inside the waiting room, and we've got a much smaller waiting room. I think the last slide's next, Kate. So we didn't do it very well. We didn't clear the decks, and it was a little bit of a mess, but we were making it up as we were going along. I think the two most important things are educate every opportunity you have. So say why you're doing what you're doing to patients and to staff as you go through, and really communicate clearly. So I deal with all the complaints, both from patients and from staff. So we had staff that had been around for a long time, that had done things in particular ways that they've always done and didn't see a reason to change. But clearly, when we spoke to them about it, they didn't have an understanding as to how general practice had changed post-COVID, and they don't have an understanding now as to the contract changes and to the way that we have to start managing patients because of NHS England. But when we've had the opportunity to explain why we're doing what we did, we were able to develop a really clear understanding. So yeah, I'd end with this quote, which is you don't rise to the level of your goals, you fall to the level of your systems. Stick with working on systems. Don't worry about the outcome. That will appear over time. And that's me.
Thank you so much. And thank you all, Devin, Bex and Johan, for coming to join us today. We do really, really appreciate it. And it's obviously so useful and insightful for everyone to hear directly from you and your experiences. Appreciate that we are out of time. There are a couple of unanswered questions. Johan, I think there are a couple for you. One about recruiting your GPAs. And then the cost of postscript, if there were. The questions that have been answered, we'll kind of collate those and we'll share them as well, so that any that haven't been answered live, everyone can see after the session as well. Oh, one of them's just gone. But yeah, thank you all so much for joining, and yeah, staying on the line and bearing with us. As I said, the resources and the deck and the recording will all be shared with you afterwards, and hopefully see you next week for week 3. And thank you very much. I will stay on the line for a moment, but if not, then yeah, feel free to jump off. And thank you, Devin, Johan and Bex, for joining us.
Thanks, Kate. Is it worth somehow capturing the Q&A? Will you have access to that to disseminate?
Yeah, we'll be able to download it from Zoom and then, yeah, exactly, disseminate it. So thank you for jumping into the Q&A as we went through.
No worries.
Thank you. See you all later.
Thank you. Bye-bye.
Bye.